Hi everyone. In this lecture we're going to cover resistance exercise or resistance training. This is chapter 6 in your book, so please review through the chapter as well, and you can follow along with this PowerPoint. So with resistance exercise, this is using any type of external force to apply some sort of resistance to the muscle. We can do this manually. You can use your own strength as the therapist to resist movement by the patient. We'll go over some techniques for this when we get into lab. And we can also go mechanically, which is probably the more common way to perform resistance exercise. So that's going to be weights, using your own body weight, TheraBand, really anything that weighs anything can be used as resistance. So I'm sure you've probably heard people tell patients you can use soup cans or water bottles or anything that they have at home to apply some resistance to the muscles. Some factors that can influence a training program are, of course, the patient's underlying pathology. What's going on with the patient? Why are they being seen in therapy? And what are they capable of performing at this point? So things like adhesive capsulitis, they're going to be lacking significant range of motion, may have difficulty doing some resistance exercises because of that lack of motion. Rotator cuff tear, I've mentioned before, initially after that repair, they're very limited on what they're able to do, especially as far as strengthening goes, like absolutely none for the first few weeks following surgery. Torn quads or really any sort of avulsed muscle or tendon, those are going to have to be rehabbed a little bit more slowly, and resistance training is going to be put on hold for a period of time. Their muscle performance at baseline, sort of where they're starting from, is going to play a pretty big role into how quickly and how much they can do as far as resistance goes. What other impairments are they a patient presenting with? What stage of healing? And this is going to be a big one. And as we get into some of the lectures that are actually coming up very soon, we'll get through and talk about what some of those stages of healing are, and sort of what an exercise program is going to look like sort of generically when you're in each one of those stages. Also, the patient's overall age and fitness level will play a fairly big role in what sort of resistance exercises you give them as well. Muscle performance is just looking at the ability or the capability of a muscle to do work. You guys have done these equations before. We're not doing them again. But this is force times distance. But again, there's a lot of other things that play into resistance training as well. Some key elements and the three major types of resistance training are going to be strength training, power training, and endurance training. And we'll talk a little bit about each one of those. So with strength training, we're looking at the greatest measurable force that can be exerted by a muscle to overcome resistance during a single maximum effort. We're going to talk about maximum effort here shortly. Functional strength is the ability of the neuromuscular system to produce, reduce, or control forces during functional activities in a smooth and coordinated manner. So not only can you do them, but can you do them smoothly, coordinated with some skill involved with that as well. When we're talking about true strength training, we're looking at controlling heavy loads for a low number of repetitions. So this is going to be a low number of reps over a short period of time, lifting heavy weights, heavy objects. Power is going to now take into account a little bit of speed. It's related to strength and the speed of movement. Think about power lifters, usually bigger people lifting heavier weights. But time plays into this as well, and that's where the speed portion comes in. There's different types. There's single burst and repeated burst types of power. Single burst would be like lifting a heavy piece of luggage onto an overhead rack or a high jump. Or if you even sort of think about this for an elderly person, a single burst of power could just be rising out of a chair, so going from sit to stand. Repeated burst, usually less intense muscle activity like climbing a flight of stairs, and this gets into or sort of bleeds into muscular endurance a little bit, which is the third type of resistance. So muscular endurance is the ability of a muscle or muscle group to perform a low intensity exercise over a longer period of time. So if you're looking at strength versus endurance, strengthening again is going to be a higher weight with a lower number of repetitions. Endurance, trying to build endurance, is going to be a higher number of repetitions with a less amount or lower amount of weights. there are going to be some patients who need to build more endurance than strength. Sometimes with our elderly population, it's more important to build endurance with them than it is to build strength, to be able to do functional activities like climb a flight of stairs and things like that. So you are going to see some overlap between all of these different types of strengthening. Again, with more of an endurance type program, muscles are going to adapt by increasing their oxidative and metabolic capacities, which is going to allow them to use oxygen more efficiently. And again, by using these low levels of resistance, that's also going to minimize adverse forces on the joints and hopefully produce less irritation to the soft tissues. So again, this is why some of our patients may benefit more from an endurance program versus a true strengthening program. And sometimes why we may actually begin with more of an endurance program and then progress on to strengthening afterwards if needed. With any type of strengthening, we need to talk about the overload principle. And basically what that is saying or stating is that a muscle has to be challenged in order for it to actually start to gain strength. A muscle has to be overloaded in order to make gains. So this is going to be looking at either the amount of resistance that's applied to that muscle and that it is incrementally increased, so that we're going to increase it over a period of time to build strength, or increasing the time that the person is performing the exercise, which would then be increasing the muscular endurance. There is also the SAID principle, or specific adaptations to impose demands, which again is basically an extension of Wolff's Law. I hope you guys all remember Wolff's Law. We've talked about it quite a few times, but again, that pertains to bone and how bone adapts to the forces that are placed on it by increasing density. So we understand that. This can be sort of applied to specificity of training as well. So basically what this is saying is if you train someone in lifting weights, they're going to get better at lifting weights. If you train someone in increasing endurance by running, they're going to get better at running. And just because someone gets better at lifting weights or gets better at running doesn't mean they're going to necessarily be really good at swimming, right? So everything is very specific as to how you train someone. Whatever method they're training with, that's how they're going to improve and see improvements that way. But if you change it up, you're not necessarily going to see a lot of carryover. So again, your improvements are going to be highly specific to the training method that you employ. So again, this is why it's really important to know what our patients' goals are. Again, thinking about an elderly patient, their goal is to be able to go up and down the stairs. So the easiest thing to do would be train them to go up and down stairs. So find some stairs at your clinic and practice going up and down stairs until it becomes easier and easier for them to do those tasks. And maybe this is something that you can't start with. So again, maybe we have to break down this task into its pieces and start with standing marching or start with tap-ups onto a step just to get them to start or initiate that taking a step. So again, depending on the patient's level where they're entering at baseline will determine sort of where we start their resistance program. There is also a principle of overflow training, and this is when the training affects muscles that aren't necessarily actively involved in the training. For example, a standing straight leg raise or standing hip abduction. As you're abducting one side, you're clearly working the hip abductors on that side, but the stance leg is also being strengthened at the same time because you're working stabilizers on that side. So that is considered to be some overflow training. Another example, which isn't quite the same, but I had a patient one time who had a bicep tear in one arm. He was a college football player and he was from another state, and the physician there sent him home for the summer, and part of his rehab was before he could begin strengthening on that repaired bicep, we actually did a lot of contralateral bicep training because there is some research to support that even training the other side, that same muscle group, there can be some overflow or carryover onto the injured side as well. So since we weren't allowed to do strengthening as that one was healing, we were focusing on strengthening the other side and some of the surrounding musculature to hopefully increase the strength of that arm once we were allowed to begin more resistance training. So that's overflow. Detraining actually happens scary quickly. And this is why it's important for patients to maintain the gains that they've made in physical therapy by continuing with a home exercise program. So really, in as little as 1 to 2 weeks, if you've ever, if you exercise regularly and then ever had to take a break off, you got sick or something like that, like you can tell it does not take long to start to lose some of those gains that you've made from exercising. So again, this is why it's really important to let patients know that it is important to continue with their exercises even once they think they're better or they've reached all their goals. We want to be able to maintain that. And again, it doesn't take long at all for those effects to start to diminish. So as far as physiologic adaptations to exercise, we all know that once you start to exercise, if you continue with it, it starts to get easier. And some of the reasons for that are your neural system or your neuromuscular system starts to adapt. And that usually occurs first. That happens within the first 4 to 8 weeks of doing regular types of exercises. And that'll include things like just motor learning of the exercises that you're doing. Your body starts to get used to them. You don't have to think about it all the time. It becomes a little bit more second nature to do those exercises. Then we start to see some skeletal adaptations, and this is hypertrophy or actual bigger muscles, growth and improvement in muscle size. So this will also occurs due to an increase in protein synthesis, and this usually takes a good 6 to 8 weeks. So that's why they say with any type of strengthening program, it does usually take about 6 to 8 weeks to start to see the results, right? So that's the changes in the muscle composition being more defined and things like that. And then we also start to see some vascular and metabolic adaptations, and that's in our type 1 and type 2 fibers or muscle fibers. So in type 1 fibers, we'll see an increase in the capillary bed density, increased mitochondrial density, and in type 2, we see just the opposite things happen. Connective tissue will also start to adapt over time, and you'll see increased tensile strength of the tendons, ligaments, and bones as well with a resistance program. Again, with the resistance program, and speaking of bones and Wolff's Law, with resistance, we're putting force on the bones as well. They're having to withstand this increased force. So we will have increased bone density with resistance programs, which will, again, come in handy for some of our patients down the road. Neural adaptations, like I said, takes 4 to 8 weeks for these to occur. This will be an increased recruitment of motor units, an increased synchronization of firing of those motor units. The muscles are going to start to get more efficient at these exercises that we're making them do. And again, this is seen in increased motor learning, improved coordination, increased ease overall with the exercise program. The skeletal adaptations, again, take a little bit longer, 6 to 8 weeks. And again, this is going to be seen as hypertrophy of the muscles. And again, the vascular and metabolic adaptations, they're your type 2 fast twitch fibers. These are your anaerobic fibers, and your type 1 slow twitch fibers are more of your aerobic type. Again, the type 1 are going to generate a low level of muscle tension, but can sustain that contraction for a long time. And then your aerobic are slower to fatigue. So your example of those are going to be like your postural muscles that are at work pretty much the whole time that you're awake, that you're upright, keeping you and holding you in proper position. So some determinants that we need to think about when designing an exercise program for our patients. We need to think about the exercise intensity, how much we're going to prescribe for them. We need to think about the exercise load, how much resistance we're going to give them. Sometimes this is just a little bit of trial and error to figure out what's going to work best for our patient. We do need to figure out how many reps we're going to prescribe them. 3 sets of 10 is not always the answer. It's very common, and you'll probably see that a lot in the clinic, but we need to adjust sometimes for that. How many sets of exercise or bouts? How frequently do we want the person to do these exercises? And with a good resistance program, whenever you're doing true strength training, you typically don't want to strength train the same muscle group day after day after day. You do want to have a little bit of rest time built in there. So at the most, we usually say every other day for strengthening exercises. For the duration of exercise, how often or how long they're going to do the exercise. Speed sometimes plays a role into this as well. And then looking at the available range of motion and how they're going to be able to perform these exercises that we give them. So sometimes we look at the strength training zone and we look at what's called an RM. RM stands for repetition maximum, and where we usually try to exercise is at some percentage of that repetition maximum. RM is looking at the greatest weight a patient can move through their full range of motion with control. So with proper form, proper execution of the exercise, the highest weight that they can actually do that. That's their repetition maximum, right? That makes sense. Maximum weight they can move through one repetition. So if they can move that weight through one repetition, we obviously wouldn't expect them to do 3 sets of 10 with that weight, right? 1 is what they could do with it. So again, typically what we do is we back it down a little bit and we give them exercises to do at some percentage of that. So again, it's going to require a little bit of trial and error, even determining that repetition maximum. Give them a weight, see what they can do. If they could go through 1 rep easily, increase the weight. If they couldn't move it, decrease the weight, and then try again there. Typically, most healthy individuals will strength train somewhere between 70 and 80% of their repetition maximum. So if they can do a maximum bench press, say with 100 pounds, if we're going to give them sets of exercises to do, we're probably going to decrease that to 70 or 80 pounds to do multiple sets and multiple repetitions of that exercise. With some other patients, if they are very early in rehab, if they are already deconditioned, this may mean that we're going to start at a much lower percent of their repetition maximum. So again, early on, we might start at like 30 to 40% of their repetition maximum, which might seem very light. But again, we want to see what the patient's able to tolerate, how they respond to those exercises. So we don't want to overload them too much too quickly. Trying to find baseline strength as an alternative to performing repetition maximum or figuring out what their repetition maximum is. And what they do is they just use a percent of the body weight based on whatever muscle group it is that they're going to use. So for example, leg extension could start at about 20% of a patient's body weight. Leg press would start at about 50% of a patient's body weight. There's a list on page 181 in your textbook that goes over a few more of these examples. But generally, this just gives you a place to start. Same thing, it's going to take some trial and error and determine whether or not this is actually appropriate for your patient or not. There are a couple of specific exercise regimens or routines that we can talk about. One is the DeLorme method, and this again is used specifically for resistance training. So what this starts with is you're going to have your patient, they're going to end up doing 3 sets of 10 with a single exercise. So the first set, you're going to start at half of the 10 RM set weight. So you figure out what the 10 repetition maximum is. What's the maximum weight that a person can go through 10 repetitions of this exercise. So then once you figure that out, then they do a set of 10 at half of that weight. The second set is at 75% of that weight. And then the last set of 10 is at that 10 RM. So you're gradually building up weight each set that you do with a brief rest period in between each of those 3 sets. The opposite of that is the Oxford technique. This is almost like a drop set. So you would start with your first set of 10 being at the heaviest weight that you can lift through 10 repetitions. Your second set of 10 would be about 75% of that, and then your third set of 10 would be about 50% of where you started. So with this one, you're starting heavy and you're getting lighter each time you go through. This DAPR method, or DAPRE, it stands for Daily Adjustable Progressive Resistive Exercise, and you guys are probably going to see the abbreviation PRE a lot, Progressive Resistive Exercise. So this one is your daily adjustable progressive resistive exercise. There's a lot that goes into this. So clinically, I can't see this working very much, but it does take into account variations in day-to-day performance of your patient. So for this particular exercise program, you would determine your initial working weight, which would be the 6 RM, 6 repetition maximum. So whatever weight that it is that your patient can safely and efficiently perform 6 repetitions of whatever exercise it is. Then you're going to do 10 repetitions at half of that. Then you're going to do 6 repetitions at 75% of that working weight. And then you'll do as many reps as they possibly can with that full weight. Then, based on the number of repetitions that they can do in that third set, then that you'll adjust your weight up or down accordingly. So there's a whole chart that you can use to kind of figure this stuff out. But again, it's a lot of math and a lot of trying to figure things out. So oftentimes we're just going to go based on what we observe in our patient. Circuit weight training, this is using resistance exercise in a specific sequence so that you get total body conditioning. So oftentimes with circuit programs, you'll do maybe like an upper body exercise, a lower body exercise, a core exercise, and like a cardio exercise. And then you just move through a circuit and keep repeating different things. So this way you're getting sort of a full body workout by working different body parts at each time. Another type of exercise is multiple angle isometrics. We will get into isometrics a lot here in just a moment. And hopefully you guys have a little bit of an idea of what we're talking about already with isometric exercises. But with isometric exercises, that whole specificity principle is going to come into play. And whatever angle it is that you're training with those isometrics, that's where the person's going to gain that isometric strength. And so we might want to consider actually having them do that exercise at different angles so that you're strengthening that muscle sort of throughout its range. So we can see physiologic overflow in a total of about 10 degrees in either direction of the training angle. But if, again, you want to move into isotonic strengthening, we're going to move through the full range of motion. And so we're going to want to have strength throughout that range. So again, it might be important to employ some multiple angle isometrics for your patients. Plyometrics, I'm sure most of you are probably familiar with that, but it's high velocity eccentric to concentric muscle loading. So where you get into your jumping and functional movement patterns, especially for your athletes. This also requires neuromuscular system involvement. And so again, these are usually saved for later in the rehab process. We need to make sure that our patient has some baseline strength and endurance before they move into plyometric training. But again, if this person is getting back into any type of sport, plyometrics are generally going to be part of their rehab program. The range of movement that a patient is able to go through may be determined by the stage of rehab that they're in as well. With range of movement, we're looking at, or the terms that you're probably going to hear a lot are things like full arc and short arc. Full arc and short arc, I think of quad exercises. A full arc quad exercise would be sitting in, say, like a 90-90 position and then kicking the legs straight out or kicking the knee out into full extension. So think about the manual muscle test that you would do to test the quads. That is a full arc quad exercise. A short arc quad exercise would be typically performed with a patient lying, say, in supine with a bolster underneath their knees, and then they're just going to kick their toes up and straighten out the quad that way. So we have shortened the range of motion through which the knee has to move to do that exercise. So again, this could be dictated by the physician, by the stage of healing that the patient is in. We use short arc motion if the full arc of motion is painful. Ideally, we're probably going to need to get to full arc for most functional activities, but also keep in mind we can still do strengthening even if the person doesn't have full range of motion. We don't always want to have to wait until the person has full range of motion to begin strengthening. So we can do some short arc strengthening within the person's available range. I'm sure you guys have talked about open chain versus closed chain before, so we won't go too far into that, but definitely remember the difference between the two. With open chain, your distal end limb segment is free. With closed chain, your end limb segment is fixed against the floor or against the wall. Open chain is usually focusing on one or just a few muscle groups at a time, whereas closed chain is going to affect generally multiple muscle groups at one time. We use open chain when weight bearing is contraindicated. If your patient's non-weight bearing, they're not going to be performing any closed chain activities yet. Closed chain is typically more functional, so that'll help to increase stability, balance, agility, and stimulate more mechanoreceptors and things like that. So again, depending on where your person is in rehab, we may sort of lean on one of these a little bit more heavily than the other. In general, to do resistance exercises, we're going to have to go against gravity for that to happen. But you guys also recall your gravity eliminated positions that you learned for manual muscle testing. So again, in some of our deconditioned or very weakened patients, we may have to start in gravity eliminated positions and then work our way up to just moving against gravity. The three major types of resistance, and I'm thinking that you guys have gone over these before already, but we are going to go over each one. We're going to talk about isometric exercises, isotonic exercises, and isokinetic exercises. Isometric exercises, again, are more static. You're going to have a contraction of the muscle without any joint movement. Your dynamic, your isotonic exercises are probably going to be the most common thing that you see as far as true resistance programs. And then isokinetic is going to be same speed or velocity controlled exercises. So with isometric exercises, again, no change in the muscle length, no joint motion is occurring, although we are getting a muscle contraction. So we can do this against manual force, even hold a weight in a particular position, pushing and pulling an immovable object. We looked at the example last term in modalities of using biofeedback with quad sets. Right? So with quad sets, we're just getting the quad to contract. The cues for the patient are to try to push their knee down into the table. So they're going to sit in long sitting with their legs straight out in front of them, or even lay supine with their legs straight out in front of them. Tell the patient to push their knee down into the table. And by trying to flatten their knee out against the table, their quads are going to fire. So that would be an isometric contraction of the quads. So we're not getting any knee movement, but we are firing the quads. We'll also go over in lab a lot of shoulder isometric exercises. So for those, typically we have the patient stand against a wall. Maybe we'll try a demonstration here. We'll see if this will go with me here. Yeah, here we go. I'm getting a little tour of my house here. So for shoulder isometrics, for shoulder extension, you can have the patient stand against the wall and just try to push, try to push their elbow back into the wall. To do abduction, they would turn to the side and try to push their elbow into the wall. The wall's not going anywhere. It's an immovable object, so you're going to push or pull into or push against the wall. And they're just going to hold it. This is going to fire my delt, but my delt's not actually moving. My shoulder is not moving. So that's an isometric exercise of the shoulder. Another way to do isometrics is to have a person hold a weight. I don't have a dumbbell with me, so we're going to pretend this pen is a dumbbell. I can do this. If I stand here with a dumbbell in my hand and my elbow bent at 90 degrees, this is an isometric contraction of my bicep. Okay, my bicep is contracted. It's not changing length right now, but it's holding a weight in my hand. So that would be an example of an isometric bicep contraction. With isometric training, again, a maximum voluntary contraction will increase the strength more than a submaximal effort. That makes sense, right? But again, sometimes we don't always want our person putting in maximal effort right away. If they're very early on in rehab, we might want them to just try to get that muscle to fire a little bit, get used to getting the muscle to contract, working at more of a submaximal level. If we increase the frequency, we'll increase strength more rapidly. So if they do these exercises more regularly, more often, their muscle will start to get stronger. We do use isometric contractions on a regular basis. Again, the postural muscles that work for extended periods of time every day, that's an endurance or an endured isometric contraction of your erectors, of your abs, in order to keep you upright. Repetitive isometric contractions against near maximal resistance has been shown to improve isometric strength, where they did 20 per day holding for 6 seconds. A lot of times with isometric contractions, we are going to have the patient hold them for about 5 to 6 seconds at a time. That's usually enough. And again, we don't want them to Valsalva or anything like that while they're holding those contractions. And then they can do a decent amount of repetitions with those. Big thing to remember is that isometric strengthening is only going to carry over into isometric strength, right? You can't do isometric contractions all day long and expect that muscle to get big and hypertrophy and a lot stronger and build up all this resistance. You have to do isotonic strengthening for that. You actually have to apply some resistance, some weights, some therabands and things like that. So isometric strengthening, though, is a precursor to isotonic strengthening. If that person is lacking isometric strength, if they can't even get a good muscle contraction, you can't put resistance on that muscle yet and expect them to do an isotonic program. So we need to get isometric strength as a baseline. Some of your patients will come in already able to do all this kind of stuff. Some of your patients are going to need to start here and work on isometric strengthening. We can also get into stabilization exercises, and these can be used at a higher level as well. So these are going to be exercises where we're just trying to increase joint stability or postural stability. So they can be performed in a weight-bearing posture or closed kinetic chain. They can also be done in an open chain as well. Again, the idea is that we're controlling more of the proximal muscles around the trunk, which will then give us a good base to work on when we're doing things with our extremities. So one example is rhythmic stabilization. I'm not sure if any of you are familiar with this. This is why it was really nice to have the 2-week internships prior to coming into this class, but we're good. We're going to get you out there and you're going to see all these things in lab also. But one example of rhythmic stabilization is when you would have your patient lying supine on the table. They're going to extend their arm up to 90 degrees and you're going to tell them to just hold it there. And then the therapist comes in and starts to try to move their arm around in all different directions, and they are trying to just hold it still. That's rhythmic stabilization. You're also going to talk about that in neuro. It's a PNF technique for strengthening. Another PNF technique for strengthening is called alternating isometrics. We use this one for balance a lot. So let's say you have a person standing with their feet together, Romberg stance, and then you just sort of touch them lightly front to back to try to knock them off balance a little bit, and they need to try to maintain good normal posture and try to maintain their balance. So this will work balance a little bit more by giving these external perturbations. So there are some PNF patterns or PNF techniques that we can use to help with strengthening as well. So moving into isotonic exercise, this is where we get into concentric and eccentric exercises. Your concentric exercises, and I'm not sure if this is going to fill in here. Nope. So you write this down. Your concentric exercises are when your muscle is going to contract and shorten, or typically seen as an acceleration of movement. Your eccentric exercises are when your muscle is going to lengthen with tension and often seen as more of a deceleration of exercise. So the muscle that's being exercised is either going to perform a concentric or an eccentric contraction, or both. Sometimes you do it both in the same exercise with either fixed or variable resistance. Isotonic exercise is going to improve isotonic strength, endurance, and power. So this is how we do strengthening and endurance training. And the exercising force, so whatever resistance you give the patient, cannot exceed their can exceed the ability of the muscle at its weakest point. As you go through the full arc of motion with an exercise, sometimes it's going to be easier to move through that arc, and other points it's going to be a lot harder to move through that arc. So again, wherever that weakest point is, you have to give them resistance that they can still overcome at that point. Dynamic and isotonic are sometimes used interchangeably, but again, isotonic is going to mean equal or the same tension throughout. Again, because of the angles and forces and things like that, resisted exercises aren't always the same. So those aren't always the same exact term. Again, when the body moves through available range of motion, the tension on that muscle because of the length relationship is going to vary a little bit. And this will change the torque that's placed on the muscles. So we'll talk about how we sort of go through that with some exercises as we move on. Typically, when we're looking at concentric versus eccentric exercising, the force of a maximum eccentric contraction is going to be greater than the force of a maximum concentric contraction. So just think about this. Always remember this. It's easier to lower a heavy load to the floor than it is to lift it up off the floor. So think about that heavy suitcase that you're trying to get into the overhead bin on an airplane, right? It's going to be easier to pull it out and lower it down to the ground versus lifting it up and getting it in there, right? So the lowering down would be eccentric, the lifting it up would be concentric. So we can control greater loads eccentrically than we can concentrically. The strength gains are going to be similar for both contraction types, but there is very little carryover from eccentric strength to concentric strength. So if you constantly work on concentric strengthening, you're going to get better at concentric strengthening, but not necessarily eccentric strengthening. Eccentric exercise is a little bit more mechanically efficient. You need greater muscle recruitment to do a concentric contraction than you would for an eccentric contraction. So when a patient comes up or rises from a chair, what are the quads doing? They are on the way up, they're concentrically contracting. See, it doesn't matter if home, work, I still can't say my words sometimes. What the hamstrings are doing when you're going from sit to stand, same thing. On the way up, they're concentrically contracting. On the way down, they are going to eccentrically contract. So on the way up, you're moving up against gravity. You're sort of accelerating that movement or forcing that movement up against gravity. So you're going to have concentric contractions. On the way back down, so that you don't just plop down in your seat, that's going to be eccentric control of both muscle groups. Eccentric contractions require less oxygen and less motor units. Concentric are going to consume more oxygen. And the velocity in which the muscle contraction is performed is going to affect the force that's generated. So again, using slower speeds are going to help to control the momentum and decrease the risk of any injury. So again, why we try to avoid really fast, jerky movements whenever we're doing any type of resistance training. Again, manual resistance is any resistance that's provided by you as the therapist. So that rhythmic stabilization, that PNF pattern I showed you, moving the arm around, that would be a type of manual resistance. And then mechanical resistance, again, is using any type of external force. So it can be a constant resistance with a fixed load or a variable resistance where you have different amounts of resistance provided throughout the range of motion. And that's where we get into like machines and things like that. Isokinetic is when the velocity of the limb is controlled. We need a machine in order to be able to do this. And it measures the motion in degrees per second. So these are old like King Kong machines, Biodex machines, which are still around in some clinics. But again, the muscle force is then going to be met with resistance depending on the speed and depending on what arc of motion that you're in. A maximum effort by the patient throughout the full range of motion, and then the muscle can be loaded throughout the full range of motion with the use of these machines. Strength gains are going to occur at the same speed at which you are training. So again, this is a speed-specific type of training. For max effort at fast speeds, you're going to see increases in power. Submaximal effort for longer periods of time, we're going to see increases in endurance. Some precautions for resistance exercise. We've talked about this before, but any patient that has any cardiac involvement, we absolutely want to make sure that they are not valsalvaing when we're giving them resistance. And when they're given heavy loads, that's when they tend to valsalva more than if you give them lighter loads. So again, this might be a person where we do more endurance type training, lighter loads, longer periods of time versus heavy loads, so that they don't cause this significant increase in blood pressure. So again, valsalvaing is they're holding their breath, they're building up the interthoracic or interthecal pressure, which is going to decrease blood flow to the heart initially. And then as soon as they release that, there's going to be a significant increase in blood pressure, and they might get some lightheadedness with that as well. So some hints that we can give the patient or tricks to make sure that they're not doing this is have the patient count out loud when they're doing the exercises. If they're counting and talking, they can't be holding their breath. Exhale when they're performing a motion. Whenever you're doing something heavy on that effort part, have them exhale. Or just have your patient talk to you. Again, if they're talking, they can't be holding their breath. So make sure that you're avoiding this, especially with your cardiac patients. Fatigue, we're looking at a decline in the muscular force and the neuromuscular system. It's a temporary state of exhaustion. We can have local muscle fatigue where we start to see a decrease in the muscular force production and a decreased response to that stimulus. Typically what you're going to see here is compensation, loss of form. The patient is not going to be able to do the exercise properly anymore. You'll start to see all sorts of crazy things. My goodness, go to the gym sometime and watch some people exercise, and the things that you will see are just astounding. Sometimes it's because they were taught wrong. Sometimes it's just because they're trying to lift too heavy and they're fatiguing quickly. So again, this is why it's really important too for us to be watching our patients do their exercises to make sure that they're maintaining proper form throughout. We can also see exercise-induced muscle soreness. Acute muscle soreness is going to happen right after the patient does a strenuous exercise, usually to the point of fatigue, buildup of lactic acid, that typical muscle soreness. This usually goes away relatively quickly, and cool downs will help to minimize the chances of this. What we tend to see probably a bit more often is what we call DOMS, or delayed onset muscle soreness. This is me for sure. But this is when it takes a good 12 to 24 hours for that soreness to start to show up. It peaks usually at the 2-day mark. So you do an exercise program, not too bad the next day, but the following day it hits you. And that's delayed onset muscle soreness. And that can last, the pain from that can last a good 5 to 7 days. This is actually micro trauma that leads to necrosis and inflammation of the muscle and the surrounding connective tissue. There is a higher chance of experiencing DOMS after doing eccentric training versus concentric training. And you'll see decrease in strength, flexibility, joint range of motion. The person is stiff and sore for a couple of days. Sometimes too, if this is a new phenomenon for your patient to experience, you have to explain that this is a normal sort of response to exercise, and it's okay to be a little sore. Because some people think, oh, I'm sore, I hurt myself again, and that's not necessarily the case. They're probably just working some muscles they haven't worked in a little while. Again, recovery from exercise, we do want to allow adequate rest periods after our exercises. Most muscular recovery is going to happen in the first couple of minutes following cessation or stopping the exercise program. Even light exercise during a recovery phase can promote quicker recovery. So those people with the delayed onset muscle soreness, like after leg day and their legs are so super sore and they can barely even move, light exercise, like just taking a walk around the block, around the neighborhood, can actually help. Because what it's going to do is that exercise is going to get those muscles moving a little bit. It's going to help to pump some of that lactic acid out of there a little bit faster, and they're actually going to start feeling better faster if they do a little bit of a light recovery. So again, it's going to help replenish the oxygen to those muscles, help remove some of the lactic acid, and start to build up the glycogen again. Overtraining is when we have either a temporary or permanent decrease in strength. You can see it in healthy individuals as well as those with neuromuscular diseases. Again, it's important to slowly increase your intensity, duration, and progression of exercise, and don't progress everything at once. If you're going to increase the weight of the resistance, don't increase your reps at the same time. So choose one or the other. So this can lead to fatigue and burnout. Can be due to inadequate rest between sessions. And again, this is usually days, right? So make sure you take a day off here and there, or at least in between training different muscle groups. Inadequate diet or fluid uptake, or too quick of a progression of an exercise program. And this is where you can get into This is also where you can see those things like rhabdomyolysis, where you have the breakdown of the muscle tissue due to doing too much at once or overtraining. So we want to avoid anything like that in our patients. So again, slow, gradual increases. Substitution, again, when your patient starts to get fatigued, this is when you're going to see substitution or compensation start to take place. So again, this is when resistance is greater to what the muscle can actually handle. So we need proper stabilization and appropriate weight selection in order to avoid this. Again, alignment, teaching your patients how to do these properly, how to properly stabilize so that they're not compensating by using other muscle groups. So again, knowing sort of the line of pull of a muscle, how it's supposed to work, will help you determine how you're best working that muscle against resistance. With osteoporosis, we do need to be a little careful with these patients because they are at a higher risk for fractures because their bones have become weaker. So typically we want to give them a lower intensity strength or endurance type program. But it is very beneficial for them to incorporate weight-bearing activities, right? Their bones are weakened, so we want to try to strengthen them. And the best way to do that, Wolff's Law, again, is to actually put some forces through the bones. So if we give them all open chain activities or give them all like a pull program where they're not weight bearing as much, then we're not going to be helping to increase the strength of their bones. So we do want to give them a resistance program. It's very important to do that, but we need to be careful about it and we need to add the resistance very gradually and slowly. So watch the patient position, avoid any high velocity movements, watch for loss of balance because we don't want them to fall and end up with a fracture that way. And we will get into this as we get into exercise for the older adult later on. But one thing we definitely want to avoid with our patients with osteoporosis is like abdominal crunches or any type of flexion of the trunk. They already might be in a flexed posture. but we don't want to put any more force on the vertebrae, so we will avoid those types of exercises as well. All right, so PNF patterns, I'm going to find some video and upload for those so that you guys can see the proper use of PNF patterns. You can flip through these slides, but again, this is probably not going to make a ton of sense to you. Use this to back up once you watch the videos. Go back through here and you can see the actual positions of each of these. So if you guys have not gone over them already, there are PNF patterns for both the upper and the lower extremity. There's a D1 and D2 pattern for both the upper and the lower extremity. So it's just diagonal pattern 1 and diagonal pattern 2. So I will find some videos to add for those so you guys can watch those and see what those are going to look like for both the upper and the lower extremity. And that is absolutely something that we will practice together in lab. All right, thank you.